afternoon and good evening, everyone. It is with great pleasure to welcome you all here today for this webinar on optoacoustic imaging in dermatology, which is organized through the Horizon 2020 project Innoderm. My name is Dr. Katja Hedicke. I'm application specialist with Itera Medical, and I will be moderating this session today and will also give you a short introduction to the Innoderm project first and then to the underlying principle of RSOM. The webinar itself will last for about 1 hour, and we very much encourage questions. So if you maximize the go-to tool, you can see that there's a question box where you can type in your questions, and we will answer them after each talk. So we have a short discussion session after each talk. The webinar will also be recorded, and we will send you the link after the webinar in the next few days. Our speakers today are different scientific researchers from across the globe, and they are all working extensively with RSOM, especially in the field of dermatology. I will introduce all of them right before their talk. Before I now hand over to our first speaker, I would like to give you a very short introduction to the Innoderm project and to the principle of RSOM. So first, the Innoderm project, it stands for Innovative Dermatology Healthcare, based on label-free spectral optoacoustic mesoscopy. You can see the logo on the right side as well as the website. So if you are interested in learning more, feel free to check out the website. This project is a Horizon 2020 funded EU project with a huge group of international researchers. So for participants of this project are Humanitas University of Milan, Itera Medical, Rayfos, Sonaxis, and the Technical University of Munich. And they all work together to develop a new lightweight portable imaging device, which facilitates early detection, improved monitoring, and accurate treatment follow-up for a wide variety of skin conditions. So here in this project, key photonic and ultrasound technologies are combined for fast diagnosis and skin disease monitoring. It should enable a quantitative assessment of morphological, physiological, and cellular changes within an affected area of the skin, which should lead to a substantial benefit for patients as well as healthcare cost savings because of reducing biopsies and individualizing patient care. The technology breakthroughs in this project are its high resolution optical imaging, which allows deeper imaging than all other optical imaging methods that currently exist. It has a unique label-free optical absorption contrast mechanism, high contrast imaging of the microvasculature and angiogenesis, quantification of tissue, lesions, and individual blood vessel oxygenation and deoxygenation. And with the device, it's possible to really image microvessel blood flow and blood volume. As that, if you are interested in the project or learning more about it, feel free to check out the website, or if you specifically want, you can also get in touch with the coordinator of the project, which is who is Professor Vasilis Nichakistos. And with that, I would like to introduce the principle behind this device, which is actually called RSOM, which stands for Raster Scanning Optoacoustic Mesoscopy. First, how does this device look? As you can see on the left side, it's a card-based system on 4 wheels, so easily movable around, consists of an LED screen, some laser warning features like laser warning lights and a laser key. For clinical setup, it has a flexible mechanical arm which can be positioned on the skin of the scanning object, like you see on the right side. So the scan arm is, for example, positioned on the lower arm of a volunteer. And this scan arm consists also the 50 megahertz detector and the laser fiber. You can also see that it has a laser safety foot pedal, which is important for especially clinical applications. It's a class 3B laser device. That's why the users need to wear laser safety goggles when they use the system. How does the image formation work in RSOM? Again, it stands for raster scanning optoacoustic mesoscopy, as the word mesoscopy already shows. It's laying between microscopy and macroscopy. So it's in the middle, and it's scanning in a raster over the field of view. So first we have the detector and the laser fiber above the skin surface, and we have first laser excitation. So the tissue is illuminated by laser light. After that, when the tissue absorbs the laser light, a short thermoelastic expansion happens of the chromophores which are in the skin, like blood, hemoglobin, and melanin, which leads to the generation of ultrasound waves. And those ultrasound waves are then detected by the 50 megahertz ultrasound detector. After that, a reconstruction happens where images are acquired with a frequency range of 11 to 99 megahertz. So this is a maximum intensity projection image of the skin from the side. So you see the skin in depth. After that, we apply frequency band separation, meaning we separate lower and higher frequencies. The lower frequencies from 11 to 33 megahertz are showing more larger or bulky tissue within the skin, like the melanin layer or bigger vessels in the dermis. The higher frequencies, 33 to 99 megahertz here in green, are showing much smaller blood vessels. This can then also be overlaid, and just based on the size of the absorbers, already the skin layers can be identified and used also for analysis. So this is for a single wavelength RSOM. If you just illuminate with one wavelength, which I will show in a second which one this is. If you are using multispectral RSOM and 4 different wavelengths, you are also able to not just do this frequency band separation and separate by size, but you can also do spectral unmixing. So you can really distinguish between melanin, deoxygenated and oxygenated blood, and then generate oxygenation maps of the microvasculature of the skin. As just mentioned, there is a single wavelength RSOM device which has the laser at 532 nanometer. And in this wavelength range, we can see blood vessels and melanin. And as mentioned, as you see on the right side, based on the size of the structures and the detected ultrasound frequencies, we can really distinguish already all the skin layers. When now switching to the multispectral RSOM, where we add 3 more wavelengths, 555, 579, and 606 nanometers, we are then able to really unmix for melanin and oxygenated and deoxygenated hemoglobin. So then you really get an oxygenation map of the microvasculature. With every image that is acquired, also you get 3D images, which can be used for this rotational videos, and these are the basis for the quantification of the images, which can be factors like skin layer thickness, blood volume, oxygenation, the diameter of single vessels, signal intensity, vessel tortuosity, or also vessel fragmentation. And you will see more of this in the upcoming talks. And with this, I would just give a short overview of which clinical research areas there are at the moment with RSOM. And now in the following talks, we will dive deeper into some of those applications. And with that, I would already like to hand over now to our first speaker, which is Dr. Andrea Murray from the Division of Musculoskeletal and Dermatological Sciences at the University of Manchester in the UK. And Andrea has a very strong research interest in scleroderma. And here, especially also the connection between the appearance of the capillaries in the nail fold and the disease status. And we are very much now looking forward to Andrea's talk. And I will hand over to Andrea and make her the presenter, and we are looking forward to your talk.
Thanks, Katja. Can you see that screen?
Yes.
Great stuff. Okay. So as Katja said, I'm based between the University of Manchester and Salford Royal Hospital. And at Salford Royal, we have a special interest in a rare musculoskeletal disease called systemic sclerosis. Systemic sclerosis is a fibrotic and ischemic disease. So by fibrosis, we mean thickening and scarring of the soft tissues in the body, including the skin and internal organs. And ischemia, the lack of blood flow in the microvessels, so the very small vessels within the tissue, which can cause damage. The next slide's got potentially a distressing image on. So if you're sensitive, I'll ask you to look away at this point and I'll tell you when I've finished. So these images, we're particularly interested in how systemic sclerosis affects the hands in patients with the disease. And these images really show systemic sclerosis at its worst. So this image on the left-hand side, you can see the claw-like hands. That's because of the fibrosis. The skin is thickened and the patient can't open their hand. You can see the ulcers here, so wounds on the tissue that occur because of the lack of blood flow, the ischemia. These can last for months. They can be incredibly painful. They can become infected. And the worst case scenario is that gangrene sets in, which can lead to auto amputation, or it can require surgical intervention to remove the digit. So you can really see here why we need to find better ways to understand what's going on beneath the skin in systemic sclerosis. So I'm on the next slide now. So in terms of the digital vascular disease in systemic sclerosis, we know that in the worst case scenario with gangrene, we've got these large vessels involved. So these are digital arteries. This was taken from someone who had no vascular disease post-mortem, and you can see the open lumen here where the blood would come through in the finger. And this is from a patient with systemic sclerosis. And you can see clearly this is an occluded vessel, so no blood's getting through, and that's what causes the ischemia further up the finger. But we know that before that large vessel disease kicks in, we've got small vessel disease that goes on. And I'm going to come back to this image in a second. I just want to orientate you a little bit first. So this is where we're looking at the nail fold just below the nail. And as we zoom in with optical microscopy, what we actually see is individual capillaries, the smallest blood vessels in the skin. And as we zoom in even closer, it's possible to visualize the individual red blood cells that then flow through those capillaries. So at the moment, the gold standard for looking at these capillaries is a technique called nail fold capillaroscopy. Until quite recently, it was a research tool. It's now used as part of the diagnostic criteria. And that's because if you look at this top image, this is an example of healthy control capillaries. You can see they're quite neat and they're straight and they're relatively narrow. At the same magnification, a patient with systemic sclerosis might present with these very wide and lower density capillaries. In terms of diagnosis, we only need to do this once, because once a patient has presented with capillaries like this, they're unlikely to get any better, because unfortunately there's no cure or treatment that can reverse this process at the moment. Although capillaroscopy is the gold standard, it's definitely not perfect, as is the case with many clinical imaging techniques. And so the aim of this study was to look at the feasibility of RSOM in order to see whether we could discriminate between health controls and patients with systemic sclerosis when we looked at these capillaries, in order to work out, could we improve on nail fold capillaroscopy in certain ways. And really the first step in that was to be able to determine the sensitivity of the system in differentiating between those two groups. So we had the system for a week, and in that time we imaged 23 patients with systemic sclerosis and 19 healthy controls. You can see capture here, demonstrating how we imaged the nail fold. And we did all of our imaging in a temperature controlled room after acclimatization, which is important for visualizing the blood vessels and allowing that baseline between the patients and the controls to be as equal as possible. We looked bilaterally, so at both hands on the ring finger, so we imaged 2 fingers for each person. And in parallel to the RSOM images, we also did high and low magnification capillaroscopy. And Katja's shown us this image earlier, just to so that you can see close up how it sits on the fingernail. Okay, so once we had taken our images from each finger, we did 3 types of analysis on those images. We did a qualitative assessment to compare the RSOM images that we'd taken with our capillaroscopy. So this is really a sort of face validity to check that what we see in the RSOM images makes sense in terms of what we would expect from capillaroscopy. We did quantitative analysis, which was to look at the blood volume within those vessels in the RSOM images and to compare that between the 2 groups. And then finally, we used machine learning. So we trained a system with those RSOM images, and then we tested it in order to determine whether we could differentiate between the patient and control group with those RSOM images. So to give you an example of the type of image that we obtained at the nail fold, you can see the curvature of the nail here, and you can see the blood vessels, the different layers of the tissue. One of the key issues we have with capillaroscopy is obviously being 2-dimensional. When we measure density, we take it in this end row, and we're never quite sure exactly which capillaries belong to that end row. So this is an incredibly helpful way to be able to visualize those different blood vessels. And you can see here some of those widened blood vessels that we saw earlier in the capillaroscopy images. Just to give you an example of how the images compare, this is our RSOM image from a healthy control, and we can see all those individual blood vessels along the edge of the nail. We can see our higher magnification capillaroscopy and our lower magnification dermoscopy. So approximately 210 times magnification. You can see it sits somewhere between these 2 sets of images. We were able to see in systemic sclerosis, you get certain patterns that occur in terms of the capillaries, and we were able to see those replicated in the RSOM images as well. So this is an example of a healthy control, the nice, neat, regular capillaries. In the patients, we saw some areas of low density where the capillaries have dropped out due to the disease. Once capillaries drop out, we start to see angiogenic, so thin, curly capillaries occurring, and we can see some of those in this image here on the end. And then, of course, in that image that we saw with the nail fold capillary image, we saw large capillaries that occurred, and again, we see those in the RSOM images as well. And as Katja explained, the colour, the false colours here represent the different frequencies in the capture of the ultrasound from those capillaries, and so we're able to use that to differentiate between large and small vessels within the images. So in terms of the qualitative analysis that we did, we can see that the capillaries in patients with systemic sclerosis, and we can see those images clearly and differentiate between the 2 groups. We can qualitatively compare those images to capillaroscopy images, and if they're taken at the same image, which is obviously is a logistics issue, then we can identify the same capillaries within the 2 sets of images. And in the RSOM images, as we've just seen, we can see different systemic sclerosis features in the same way that we can with capillaroscopy. So that's all very positive. In terms of vascular volume, when we compare the amount of blood volume in those images, we see, so this is blood volume here on the left. We've got a healthy control group on the left here, and then our systemic sclerosis group here. And we can see an increased volume in those healthy control capillaries, which is what we would expect given that we get a lower density of vessels for patients with systemic sclerosis. So again, that's a positive finding that matches with our previous findings of lower density in the patient group. And then finally, when we trained and tested our machine learning model, we generate a receiver operating curve. For those of you who are not familiar, we've got a true positive rate here. So we feed in an image that we say is systemic sclerosis, and the machine recognizes it as systemic sclerosis. A false positive rate would be the opposite. So we feed in a patient's image with systemic sclerosis and it thinks it's a healthy, it thinks it's systemic sclerosis when actually it's healthy control. And if we plot those together, the area underneath that receiver operating curve, the higher it is, the better accuracy the machine learning model has at differentiating between those two groups. And we can see here we've got an area under the curve of 0.9, which means it's very good at differentiating between those two groups. And here on the right hand side, with a prediction score of 0 being healthy control and patient being 1, we can see that those images that were actually healthy controls are in general graded as healthy controls, and those that are systemic sclerosis are in general graded as systemic sclerosis. So this is, again, even though we've got to acknowledge that there were not a huge number of patients in the study, given that we split those images into strips and generated significantly more images, this is a good outcome in terms of differentiating between patients and controls. So in conclusion, this small feasibility study has shown us that RSOM is very much a complementary method to nail fold capillaroscopy. It offers us a state-of-the-art technique to elucidate the pathophysiology, so the underlying changes in the vascular beds of systemic sclerosis. The three-dimensional imaging is incredibly helpful, and it will be very useful going forward to identify those distal row capillaries. And the fact that we can extract the blood volume means that potentially that quantitative method will allow us to increase sensitivity. Our system that we now have allows us to look at oxygenation, which again will increase the functional measures that we can make in the future. And so we're very positive, and we believe that photoacoustic imaging has got great potential as a non-invasive vascular monitoring tool in systemic sclerosis, and as I'm sure we're going to hear in other dermatological diseases as well. And just to acknowledge the team that took part, particularly Sonia and Joe, who did the imaging, Katja, who came to Manchester and helped us set up the system and did the blood volume analysis, and Suhanya, who did the machine learning model for us. And we're very grateful, obviously, to all of our participants. Thank you.
Thank you very much, Andrea, for this very interesting talk. There are quite some questions here, and I would maybe like to ask 2 or 3 of them, just because we don't have time for all of them. But what do you think of only the effects on the nail fold? Or could you also imagine to study other areas of the skin for systemic sclerosis?
I think that's one of the quite exciting things about the technique. So at the moment, the only way you can visualize those capillary loops in 2 dimensions is at the nail fold as the skin dips down below the nail. Everywhere else in the skin, the capillaries sit so that they're perpendicular to the surface of the skin. So suddenly being able to do 3-dimensional imaging of capillaries means that you can image anywhere on the skin to look and see whether those capillaries are changed across the body. And that's something that, as far as I'm aware, hasn't been done before, but it's definitely on our plans. We're in lockdown at the moment, but when our patient studies restart, we plan to look and see if we can see that.
Okay. And was RSOM imaging restricted or even more difficult due to the hyperkeratosis?
I think, again, one of the advantages of the RSOM is that because it's preferential, the wavelength that we use, the 532 nanometers, is preferentially absorbed by the hemoglobin. It travels through the skin because there's no hemoglobin in the skin that's not got the blood vessels in it. So unless there's a lot of melanin in there, it's preferentially absorbed by the blood vessels, which means you can still get through that keratin in the skin. So I think it's less of an issue with a multispectral or a spectral-based technique than it is with the optical imaging that we do with capillaroscopy, which can sometimes be a little bit problematic.
Okay. And maybe a last question, did you also try to compare different nail folds, so different fingers, and was there any difference, or do they extract the same features for each patient?
We did 2, so for this study we did 1 finger on each hand. If we'd had more time, we might have done more fingers. We know from capillaroscopy that the patterns can differ if we image different fingers on the hands. In studies we've done before, the ideal situation is to image all 8 fingers. So we exclude the thumbs because they're difficult to image. So in an ideal world, you would do all 8 fingers because we know that we can see differences across the finger. But for this particular study, we just looked at 2, and we didn't compare to see how different those were in this study.
Okay. Thank you very much again, Andrea, for this nice talk and answering the questions. And I would now then like to introduce our next speaker, Dr. Dinish, US. I will already share with you. So Dr. Dinish is a group leader at the Laboratory of Biooptical Imaging at the A*STAR Singapore Bioimaging Consortium. And one focus of his work is on dermal photoacoustic imaging, in particular the use of RSOM imaging for disease severity assessment and treatment monitoring in atopic dermatitis. We are very much also looking forward to your talk, Dinish, and I would like to now hand over to you.
Thank you. My screen is clear. Am I audible?
Yes, all clear.
Okay. Okay. Thank you, Katya, for this introduction, and thank you for inviting us for this presentation. Hello to all of you, and greetings from Singapore. In this talk, let me take you through our recent highlights of our optoacoustic journey, specifically RSOM, for skin inflammatory condition, that is eczema. Okay, so this is the outline of my talk. I'll be giving a brief overview of what is eczema in prevalence and the existing subjective scoring system used for eczema, then RSOM imaging and how it is used to evaluate the severity of eczema. Then RSOM we also use to evaluate an eczema biologic treatment response, and finally I'll give you a summary. So first, what is eczema? Okay, so eczema is a common chronic inflammatory skin disease with huge patient burden. It is actually characterized by intense itching sensation, scratching, and eczematous lesion with dry, scaling, and crusted area of skin, and it often leads to lichenification, that is thickening, and pigmentary changes. Frequent flare-up, varying frequency, and period of remission is a common feature of eczema. It is often flares up when you are stressed or under pressure, because the stress hormones can lead to increased inflammatory markers. Interestingly, among kids, students, it can often flare up during examination times. Eczema typically occurs in individuals with personal or family history of asthma or allergic rhinoconjunctivitis. Lifetime prevalence of eczema is in the range basically from about 10 to 30% in children and 2 to 10% in adults. In Singapore, it causes a huge patient burden. In 1 in 5 children and about 1 in 9 adults have eczema. Individuals with eczema tend to have self-reported history of hypertension and adult onset of diabetes, even with controlled body mass index and other comorbidities. Now, in infants, it can be seen primarily in face and scalp. In childhood, severity might occur in the extensor, wrist, or ankle, while in adolescence and adulthood, it can be dominant in necks or eyelid. Though distribution is not limited to some particular regions, it has some trends as a function of age, and severity vary accordingly. Now, let me take you to one of the common subjective scoring system used for eczema severity analysis, which is SCORAD, which stands for Scoring of Atopic Dermatitis. It has 3 parts mainly, the score. One is the area of the body, intensity, and subjective symptoms. Area involved basically in an extent of 0 to 100, which contributes to 20% of the total score, while intensity constituted by 6 items, that is erythema, swelling, scratching, oozing, lichenification, and dryness. And this contributes to 60% of the total score, and each of the items which I mentioned in a graded in a score of 0, 1, 2, or 3. Last component, which is a subjective symptom, basically itch and sleeplessness, graded in a scale of 0 to 10, and which constitutes 20% of the total score. Generally, mild eczema has a SCORAD score less than 25, Moderate eczema has a score 25 to 50, and severe eczema with a score more than 50. So what is the drawback of this scoring system? Okay, there is one more scoring system which is used for eczema, that is called EVSI, which stands for Eczema and Severity Index, which I'm not going to detail here. So among the eczema scoring system, as you can see here, this system which I mentioned, either SCORAD or eczema, which are purely subjective. It can be vary based on clinical observation and questionnaires, and hence it is subject to intra and inter observer variation. Some clinicians say that when they do a SCORAD scoring 2 times of the day for the same patient, the score can still vary. That shows that how subjective it is. Visual examination also fails in the detection of subclinical skin structural changes that might not be apparent. And it also not able to provide objective assessment to treatment response, and also not able to provide information about associated comorbidities. So in this context, we want to address the unmet clinical need of developing a unique objective scoring system of looking at objective scoring system using RSOM imaging to look at the eczema severity. As you can see here, the cross-sectional RSOM image of 3 patients with varying severity of eczema are shown here: healthy, moderate, and severe. Our study cohort actually consists of 91 subjects. Out of the 24 are females, and majority, about 95%, were in a Fitzpatrick skin type 3 to 4 due to mainly Asian population. In these images, you can see the low frequency bands in the 11 to 33 megahertz, which represents the red color, indicates the big vascular structures, while the high frequency band in 33 to 99 megahertz indicates a 33 to 99 megahertz in the green color indicates a smaller vascular structures. As you can see here, the uppermost layer, epidermis, epidermis is followed by the dermis, and the cutaneous blood vascular architecture consists of a lower and upper horizontal plexus. The capillary loops you can see mainly in the severe eczema cases. This capillary loops shows like a dotted structures in this image. We deduced 4 metrics, which is epidermis thickness, ET, total blood volume, TBV, vessel diameter, and ratio of low and high frequency component. That means it is a ratio of red to green structure. To calculate total blood volume, TBV, we set the voxel to be 1 when its value is above a particular threshold, and the rest of the voxel to be 0. And TBV was taken as the total count of the number of voxels with the value 1 in the segmented dermis. To evaluate the vessel diameter, the selection of blood vessel has to be parallel to the skin surface as much as possible, and in the same depth in the dermis for comparison. As I mentioned, ratio of low and high frequency component, this metric basically represents the ratio between the big and small microvascular structure in the dermis. Now, representative RSOM image of a healthy subject, then an eczema subject with a non-lesional area, then mild, moderate, and severe cases are shown here. You can see the big vascular structures in red appeared more prominent in eczema patients, and we could also show an increasing trends for these metrics, especially for epidermal thickness, TBV, LHFR. Quantitatively, we deduced the epidermal thickness, and we found that for the healthy skin, it was about 130 micron, which is increased up to 400 micron in severe case of eczema. While you can see TBV, total blood volume, has a 3 times increase compared to the healthy skin in the case of severe eczema. Similarly, about 50% increase in LHFR metric, which we calculated between healthy compared to moderate or to severe case of eczema. Notably, there is an increase in vessel diameter in the eczema subject, which is about 35 to 40 micron compared to non-lesional or healthy subject, which is about 25 micron. But there is no significant difference between mild, moderate, and severe eczema in the case of vessel diameter. We could also see, if you see the severe case of eczema image here, you can see enlarged capillary loops, which reflects higher skin inflammation. Next, we used a linear kernel support vector machine SVM model classifier model for classification of this healthy subject versus eczematous skin. As you can see here, we achieved an accuracy of about 87%, sensitivity about 96%, and specificity about 82%. Next, we formulate the eczema vascular and structural index EVSI, which is primarily constituted by epidermis thickness, TBV, and LHFR. Among these, the epidermal thickness is the major contributing factor. This index was, as you can see here, this index was able to distinguish the extent of eczema's severity. You can see an excellent correlation compared to the SCORAD score. And the PSN correlation test showed an excellent correlation between this EVSI score and the SCORAD score. So this shows that our EVSI score can be used as a objective scoring method to delineate the extent of the severity of the eczema. Finally, we use this method, RSOM imaging, also to look at the monitoring the treatment response in a biologics subject patient. We used dupilumab. This is the first biologics tried in Singapore for adults with uncontrolled moderate to severe atopic dermatitis or eczema. It targets the signaling of IL-4 and IL-13 cytokines involved in the underlying inflammatory process in eczema. Biologics treatment was tried in a 67-year-old male subject, and he was diagnosed with eczema since the age of 6 and had previously used topical corticosteroids therapy and phototherapy with minimal effect. We imaged this subject 4 weeks before treatment and 4 weeks before treatment and 4 weeks after treatment to visualize the skin morphology and vascular changes. If you can see this image, it is obvious that an irregular and thickened epidermis prior to treatment is, that means the one on the left, okay, prior to treatment is changed to more regular and less thickened epidermis, as you can see in the right side in the image B here. Also post-treatment, we could see a reduction of enlarged capillary loops, decreased total blood volume, and reduced diameter of the vessels. Quantitatively, we observed a reduction of 32% in epidermis thickness, 10% in total blood volume, and 20% reduction in vessel diameter. These results were validated using standard TWL, transepidermal water loss measurement, and serum biomarkers. This study shows that photoacoustic imaging or optoacoustic imaging can detect subclinical changes that may not be apparent clinically, and it also allows for repeated measurements over time. Hence, it potentially serves as a treatment monitoring target in addition to serum biomarkers. In our ongoing study, recently we just published a paper in Biomedical Optics last week, where we conducted a comprehensive analysis using 3 machine learning tools using random forest, SVM, and CNN for classifying eczema versus a healthy subject. Through this, we could find that CNN model successfully differentiated healthy versus eczema subjects with a 97% of accuracy. And currently, we are extending the study with a large cohort, which is ongoing study in National Skin Center in Singapore. Finally, the summary. So for the first time, we developed an optoacoustic-based structural imaging approach to differentiate the severity of eczema. We developed a quantitative imaging metrics and proposed an objective scoring system, which is EVSI. For the first time, this RSOM imaging was used to quantitatively track the progress of biologic treatment response. Finally, let me express my acknowledgement to entire team, Laboratory of Biooptical Imaging at Singapore Bioimaging Consortium, A*, headed by Prof. Malini, and also to all the collaborators here. We set up, as BIC, we set up the first joint lab with ITERA to advance the imaging approaches of photoacoustic for preclinical and clinical imaging in Singapore. Also to our clinical collaborators, Prof. Stephen Theng, Dr. Yikwing, and Dr. Sai as well. And also to our collaborators, Prof. Vasilis Huan and Prof. Daniel Rosensky. Finally, thank you. Thank you for your attention.
Thank you so much, Dinish, for this very interesting talk. And also for you, there are a few questions. So maybe the first one is, when you monitor treatment effects over time, how can you make sure to always image the same spot if the disease is spread out over a larger area of the skin?
Yeah, okay, if I go back to that image, okay, let me go to the image. So what we did is that if this is a subject, we measured the distance from the wrist and this joint, and similarly here, so we more or less calculated this point, and we measured in the subject at the before treatment and after treatment.
Okay, maybe in relation to these questions, how do you get a severity impression of all lesions?
If I understood correctly, how we calculated, or how the clinician calculated using the existing method?
How do you get an impression of how severe the disease is just by measuring one spot?
Oh, okay. Good point. So, okay, what we did is that we did repeat this in a couple of other locations as well. Okay, so we want to have a feel how there is a response. So for the clinician after the treatment, he don't have any quantitative way to see the changes. So basically, that will help him into further treatment, and also the dosage. So we measured actually in a couple of locations the volar forearm. So this is one of the representative image I shown here. Question correctly.
Okay. And then one last one. What is the lowest threshold of the scoret where you could see the first visible RSOM changes of this scoret index? What's the lowest threshold?
So okay, so in the mild case, we had a subject varying between as small as low as about 5 to 10 onwards, we can see. Okay, so the in this case, if you look at the patient load, which is in my previous slide, we have a mild case which is about 26 subjects, so which is vary between 0 to 25. So we have cases even with a scoret score of less than 10 as well.
Okay. Yeah, thank you very much again for your great talk and for answering these questions. And I would like to now hand over to our next speaker, Dr. Amalina Binte Ibrahim Attia. And Amalina is also working as a scientist at the Laboratory of Biooptical Imaging at the A-STAR Singapore Bioimaging Consortium. And her main focus is intensively on the use of optoacoustic imaging for disease staging and monitoring. And today she will be presenting on the use of multispectral RSOM for monitoring microvascular changes within the skin during occlusion. And we are very much also looking forward to your talk, Amalina, and I would like to hand over to you. And you are muted. Oh, okay.
Thank you. Sorry.
Now,
thank you, Katya, for the introduction. Sorry, you can hear me, right?
Yes.
Yes, all right. Thank you, Katya, for the introduction. Good morning or good evening from Singapore. As Katya said, I'm Dinish's colleague in SBIC, and previously Dinish has presented on the eczema condition and using RSOM, and I'll be presenting on the use of multispectral RSOM to monitor microvascular hemodynamic changes in a healthy population. So skin hemodynamics can be described as blood perfusion or its oxygenation state, and it can be a measure for monitoring tissue metabolism and detection of disease manifestation. also diagnosis of skin inflammatory diseases, and it can also be used as a measure to assess tissue viability during intervention and recuperation. So in this study, we want to test the capabilities and sensitivity of multispectral RSOM in spatially mapping the human skin absorbers and to monitor their changes upon occlusion stimuli. So the multispectral RSOM can be imaged at 4 wavelengths listed on the slide, which coincide with the peaks and isobastic points of the absorbance of the hemoglobin absorbers, oxyhemoglobin, deoxyhemoglobin, and melanin chromophores. So with a combination of the wavelengths used for the image acquisition, we can unmix for blood from melanin in the epidermis, for example, and we can also obtain oxygen saturation values in the blood vessels. So our study protocol is such that the scanning head of the multispectral RSOM is placed on the ventral forearm with the cuff placed above the band of the elbow. So when the cuff is inflated, we will simulate venous occlusion and also arterial occlusions. And because the RSOM can only acquire at discrete time points, we acquire images on the same region of interest on the forearm at baseline, and at first and third minute of venous occlusion, and at 2 minutes post-release of the cuff, and again at the first and third minute of arterial occlusion, and finally 2 minutes post-release. So here we have the cross-sectional optoacoustic image of the human skin in vivo during a venous occlusion challenge. So the epidermal layer is characterized by the melanin absorption, while the vascularized dermal layer is characterized by the hemoglobin contrast contributed by the deoxy and the oxyhemoglobin in the blue and red signals. And similarly, the hair on the skin is shown as the melanin signal. So what we observe is that during the venous occlusion challenge, an increase in the deoxyhemoglobin signals and an increase in oxyhemoglobin signals is shown, and that the increase peaks at the third minute of occlusion before the signals reduce upon release of the cuff. Interestingly, the deoxyhemoglobin signals increase drastically during the occlusion compared to the oxyhemoglobin signals. And by calculating the oxy and deoxyhemoglobin values, we can get the saturation values presented here in the heat map. And the RSOM oxygenation values show that at baseline, most of the vessels are above 50% saturated, which is characterized by the red and the yellow signals. And that during the venous occlusion, the blood saturation level decreased, where you can see more green signals signifying less than 50% saturation level. So this decrease in blood saturation level can be attributed to the disruption of transport of deoxygenated blood from the peripheral blood vessels back for gas exchange. So looking at arterial occlusion, whereby the arterial inflow and the venous outflow is impeded, we can see that similarly an increase in deoxyhemoglobin signals was observed during the challenge, but in this case the oxyhemoglobin signals decrease during the occlusion, and that this simultaneous increase in the deoxy signals and decrease in oxyhemoglobin signals is indicative of the blood oxygen consumption in the blood vessels, since no supply of oxygenated blood is being delivered. And upon release of the cuff, both of these signals return to near baseline values. So similar to the venous occlusion challenge, the oxygen saturation level decreased during the arterial occlusion challenge, and that this decrease is due to the oxygen consumption in maintaining metabolism, since there is a limited delivery of oxygenated blood. And again, at third minute of the occlusion, you see more green signals signifying less than 50% of saturation. And again, upon release of the cuff, the saturation values return to near baseline values. So from these images, we can quantify each absorber, deoxy and oxyhemoglobin signals, and we can get the total hemoglobin. And when we measure these changes on 6 subjects and we average it out, and we plotted these signals as shown. So during venous occlusion, the increase in overall total hemoglobin is probably due to the increase in blood volume as the blood accumulates from the blocked venous outflow during the occlusion. But on the other hand, during arterial occlusion, we expect the total blood volume to remain steady since there is no, since the inflow and outflow of the blood is impeded, and this is shown from the RSOM images. So naturally, the oxygen saturation values would decrease during the occlusion challenges, and that the saturation levels decrease further for the arterial occlusion compared to venous occlusion. So we can also look at the images at one particular wavelength, the 532 nanometers, similar to RSOM. And when we separate the signals to the high and low frequency, we observe that the low frequency and high frequencies intensities actually increase during the venous occlusion, with the peak occurring at the third minute of occlusion, while during the arterial occlusion, no discernible differences in the low frequency and high frequency signals were observed. And this is probably due to the fact that the blood accumulation occurs during venous occlusion. And since the two frequencies represent the different sizes of the structures, as Katia mentioned, so we can probably infer that both the smaller and the bigger vasculature structures actually do exhibit the same hemodynamic response to the venous occlusion. So previous multispectral RSOM images were obtained from bulk calculations of the two absorbers in the whole 3D images. So we also want to investigate the sensitivity of the system when measuring the hemodynamic variations in single vessels in a small area. So we demarcate the single vessels in the white box, and what we found that the hemodynamic trends of the deoxy and oxyhemoglobin signals in the small area is consistent with that of the bulk calculations from the 3D images, whereby we see the deoxy signals increase during both occlusion challenge, while only oxyhemoglobin signals decrease during the arterial occlusion. So the multispectral RSOM technique definitely demonstrates promise and sensitivity for visualizing and quantifying the hemodynamic response in single vessels, especially in a small area of interrogation. So in summary, we have shown that multispectral RSOM can image microvasculature at high resolution, and it is capable of monitoring hemodynamic changes, and it can quantify deoxy and oxyhemoglobin signals upon occlusion stimuli, and that different size of vessels demonstrate the same hemodynamic response, especially during venous occlusion, and that these hemodynamic trends are also observed in single vessels in a small area of interrogation, showing the sensitivity of the multispectral RSOM. So with that, I'd like to acknowledge my colleagues from SBIC, Dr. Mohesh, Dr. Suting, Dr. Dinish, in this for the help in this study, and also SBIC ITERA Medical Joint Lab and our clinical partners in NSC. So yes, thank you for listening to my talk.
Thank you, Amalina, for your very interesting talk and this presentation on multispectral RSOM and how this can be used to really measure oxygenation changes in very small microvessels in the skin. And there are also a few questions. So the first one is, how do you make sure to occlude the veins but not the arteries?
Yes, so there are many references in the literature, and that one particular reference is that we occlude at 80 millimeters to achieve the venous occlusion.
Okay. And is the imaging system, so the multispectral RSOM, capable to demonstrate tissue oxygenation levels also in healthy subjects before and after treatment, either topical or injection treatment? So he means, is it possible to also monitor very, very tiny changes also in a healthy population?
Well, we have not done such studies before, but I remember, Katya, you do have a study where you put a heating gel on the skin.
Yeah, so
and the multispectral RSOM was able to visualize the differences.
Yeah, so
right?
we use capsaicin cream on healthy volunteers, and we could really monitor changes within few minutes. And as Amalina showed also, it's really possible to analyze single vessels. And here the changes, even if they are small, can already be detected. So I think if you apply something topical or inject something also in healthy skin, it's definitely possible to also monitor that. And how about other absorbers? Could you also image anything other than oxygenation in blood or melanin, such as lipids or collagen fibers within the skin?
Well, since the multispectral RSOM is only limited to the 4 wavelengths that was shown earlier, which was only up to 606 nanometers, so I think it's only able to visualize melanin and the hemoglobin absorbers.
Okay, then thank you again, Amalina, for this interesting talk and your answers. And with that, I would now like to hand over to our last speaker for today's webinar, Dr. Juan Aguirre from the Technical University in Munich, Germany. And Juan is the group leader of the Optoacoustic Mesoscopy group and one of the RSOM pioneers. So he was really involved in developing these optoacoustic imaging technologies and is very much working on the applications of this device in the biomedical field, especially for different kind of skin conditions. And today he will share some very interesting insights with us on precision monitoring of psoriasis treatment. And we are also very excited to hear your talk. And with that, I hand over to you, Juan.
Katya, thank you very much for the introduction. I guess you can see my screen. Everything is fine.
Yes.
All right. So yeah, as Katia said, my name is Juan. I'm Juan Aguirre. I'm group leader at the Optoacoustic Mesoscopy group. Let me see if I can switch. Okay. This is the index of my talk. I will make a very brief introduction to clinical RSOM because already Katia made a very nice introduction, and so just a couple of slides, a couple of images very fast. And then I will talk about psoriasis severity assessment and how RSOM sees psoriasis. So psoriasis according to RSOM and comparison with histology. And then I will talk about how we can do psoriasis therapy monitor with RSOM and the advantages that this brings. And also I will talk a little bit about repeatability. What is the repeatability of the RSOM images regarding regarding psoriasis and measuring biomarkers of psoriasis. So yeah, very fast. Already Katia showed this, so I want to stop here. So for do raster scanning optoacoustic mesoscopy, you just take a transducer, you scan it over the skin, and with ultra bandwidth, you can reconstruct nicely with very high resolution, very deep, the distribution of the main light absorbers. You get the distribution of melanin and the distribution of hemoglobin. For example, if you use green light, and you get this kind of cross-sectional images. Already Katia showed at the beginning that, yeah, you can see the different skin layers, you can see the different vascular structures, and it's a view of the skin it's a view of the microvasculature of the skin that is completely new, and other techniques cannot show these cross-sectional images with the same resolution to depth ratio. So now, regarding psoriasis, I will slow down a little bit. So psoriasis is an example of a possible robust application of a clinical application of RSOM. Psoriasis is a chronic disease, and it's a chronic inflammatory skin disease, and there is no cure for it. And in its acute phase, it can be severely disabling, and it is highly prevalent. So one of the unmet clinical needs of psoriasis, one of the main problems of psoriasis, apart that there's no cure for the disease, is that severity assessment is done using the so-called PASI index, which is an index that is derived by visual inspection. And then visual inspection, obviously, it's always subjective, and it's not robust, and it's not accurate, right? So the accuracy is low and the precision is low. This visual index measures different or gives a score to different properties of the plaques, so redness, endurance, also the level of scaling, and so on. And yeah, the fact that it's subjective and then the accuracy is low has negative consequences for therapy monitoring, which is very important, especially with the new biological treatments that have been developed for psoriasis. So these treatments are very expensive. So you really want to know if the treatment is making an effect or not. And also for drug discovery, right? Because when you test new drugs, you really want to know if you are sure that you are making an effect, that the drug or the possible drug candidate is making an effect or not on the plaques or on the disease. And also for precision medicine, for this new paradigm of N=1, right? The paradigm of precision medicine, it is very important to know if therapies are working or not. Okay. So then what we did is we tested we brought our RSOM system to the clinic, and we imaged a psoriasis plaque, and we immediately saw that we immediately realized that with RSOM we can observe some of the most relevant hallmarks of the disease. We can nicely observe some of its pathological features. So on panel A, you see a cross-sectional view of healthy skin, and on panel B, you see a cross-sectional view of a psoriatic plaque according to RSOM. And we can observe how the capillary loops get larger and thicker. And also we can observe a great deal of vasodilation. So the blood vessels in the upper plexus get thicker, and there is in general a very important increment of vascularization. And this is all this involvement of the vascular structure, of the microvascular structure, and also the elongation of the acanthosis, right? The elongation of the the increment of the thickness of the epidermis, and then the elongation of the capillary loops. All this is very well described. These are some of the main hallmarks of psoriasis. And yeah, it was really pleasant to see that RSOM reveals these hallmarks so nicely. Then, of course, we want. Well, this is another example. For example, in these slides you can see. So, for example, in panel A, we show an image of the skin of a healthy volunteer, and then the white arrows point to the capillary loops in the epidermis, and then we can observe in the upper plexus. We can observe the upper plexus and the connecting vessels, and then in panel B, corresponding to the psoriatic plaque, we can see how the epidermis get thicker. Again, the acanthosis. We can see how the capillary loops grew and get larger, and so on. And then it's also interesting to see the images from the top view. So this is what you can see in panel C and D, just for the region of the epidermis. And yeah, well, if you see only the epidermis from the top view, mainly what we see is the tip of the capillary loops. And then we can see how in the healthy skin, the capillary loops are distributed more or less randomly, while in the psoriatic skin, the capillary loops have certain degree of order. They are distributed more or less evenly, and we can see how the thickness or the diameter of the capillary loops increases. Of course, we made comparisons with histology to double check or to really be sure that what we are seeing is true, and there is a histological correspondence. And again, so if you look at the left, psoriatic skin, we can nicely see the correspondence between the RSOM image and the histology image. And yeah, the epidermis thickening, and then the tip of the capillary loops. This is important because when the capillary loops go in direction perpendicular to the skin, we can only see the tip. We don't see the rest of the capillary loops. And then the dermis and the increment of vascularization in the dermis and so on. And then if you go to the right, you can see the healthy skin. And yeah, again, we were able to compare the epidermis thickness and also the thickness of the microvessels and so on, and really be sure that what we are seeing is real. Okay. And then, of course, we wanted to derive biomarkers for quantification, to do basically objective quantification and go beyond the subjective quantification. And then we found several biomarkers that we could nicely calculate from the images. For example, the blood volume per skin surface, the fractal number, and very importantly, the epidermis thickness. So before Dinish was talking about the epidermis thickness and its importance also in eczema. And we could see that, yeah, we could derive some objective quantitative metrics that were different in psoriasis skin compared with adjacent healthy skin. So then, since we have quantitative biomarkers, and we have so RSOM can show nice images of the pathology of psoriasis, and we can measure quantitative biomarkers from the RSOM images. We wanted to see what happens if with monitor therapy, right? So then, on top in panel A, B, C, and D, you can see clinical images of a psoriatic plaque, and then in the clinical images you can see ink dots, and these ink dots serve as a reference for us to make sure that we will always measure in the same position. So this is a question also that pop up in the talk of Danish, right? So how can you measure in the same position every time? So since for this example, we are only looking in a range of a few days, not a few weeks, we can make these markers, these ink markers, and then keep them in the skin, and they don't get deleted. And then like this, we are sure that we're imaging always in the same place, because the ink markers appear nicely in the RSOM images. So in panels I, J, K, and L, we can see the corresponding RSOM images, and we can see very nicely how the therapy what is the effect of the therapy on the psoriatic skin. So basically, we can see how the mean length of the capillary loops gradually decrease, and also the thickness of the upper plexus decrease, and also we can see how the diameter of the capillary loops also decrease. So these images are very interesting because we can see that from day 8 to day 10, there is no change in the PASI index. So if a clinician would see this patient, or many of the clinicians would see these patients because the index has a high degree of subjectivity, he would think that the therapy is not making any effect. However, you see there are some images, you can nicely see that the therapy is still making effect because the basically the mean length of the capillary loops, which is MLL in the panel I, it decreases between K and L, all right, between panel K and panel L. So yeah, this is in our opinion, this is important. So this may have importance for the clinic and also for drug discovery. And yeah, we made a very large study on this, more than 80 measurements, and we are in the process on writing the paper. And our conclusion indicates that RSOM can capture therapeutic effects even when visual observation cannot. Another thing that we wanted to see is the repeatability. So these images has medium quality, medium high quality, and we wanted to know even if the quality is not as good or is not the best, if what happens if we do one experiment at time 0 and then one experiment a few minutes after, in order to measure repeatability, in order to measure the precision. So we know that the accuracy of the system is related to the actual resolution, especially for the most explicative biomarkers, for example, the plexus thickness. But then the question is, what happens to the precision, right? So we've done this repeatability study. Sorry, there is a mistake here in the title. It's repeatability, and basically we did a lot of measurements at time 0 and then 10 minutes after, using our technique of the ink dots to make sure that we are imaging in the same position. And we were able to repeat the measurements, or repeat the quantification of the biomarkers very nicely with a high precision. And right now we are processing the data. We are doing the statistics. We have many measurements here, and yeah, I recommend you to stay tuned if you are interested on the results. And hopefully we will publish this pretty soon. But the take-home message is that the accuracy is high, obviously, because it's given by the actual resolution, but the precision, which is related to repeatability, which is related to systemic errors you may make while doing the measurements. For example, are you able always to measure in the same position? What happens to other systemic errors, like, for example, motion and things like this? And our results indicates that for the main biomarkers, for the most explicative biomarkers, the repeatability is very high. So yeah, just to conclude, our results strongly suggest that RSOM can perform precision therapy monitoring of psoriasis, and this may have a possible impact in drug testing and also for precision medicine, and also maybe for the clinics if medical doctors are interested on looking at a very fine detail what is happening with the drugs that they are prescribing to the patients. And yeah, acknowledgements, of course, Professor Vasilis de Christos, the director of my institute and one of the minds behind RSOM. And yeah, also, of course, the Optoacoustic Mesoscopy group, all the members of my group, and also our clinical collaborators. And yeah, thank you very much. Questions, please.
Thank you, Juan, for this very, very interesting talk, and it's really nice to see how this is really moving forward. And of course, there were also some questions. So the first one is very nice results on treatment assessment. Do you think it's also possible to use this as a prediction tool for treatment? So do you think that when treatment started and you use RSOM, you can have a faster decision compared to visually visible?
Yeah. Yeah, so obviously I'm a physicist and a mathematician, so no, I'm not a clinician. But so the clinical relevance is more I mean I cannot make prediction about clinical relevance, but what I can tell is that yeah, if you're so if you want, so with RSOM we can see definitely subclinical effects of the therapy. So effects that cannot be observed right now with current clinical tools. So then the question of whether these subclinical effects will have or the impact of these subclinical effects, what will be the impact of this, of being able to see these subclinical effects? This is a question more oriented for clinicians, I'd rather say.
Mm-hmm. Okay, another one is, which ink did you use as a marker that can stay for 10 days or more on the skin?
Yeah, so the thing is that these patients were in the hospital, and what we were doing is that every day, actually twice a day, we were visiting them and we were marking again these dots. So obviously you have to follow up the dots constantly. So you don't put them once and then you leave them and then 10 days after you measure again. No, every day, twice per day, you go to the ward, you go where the patient is, you go to the bed of the patient, and then if the ink dots are about to disappear, you overwrite them a little bit, and also you instruct the patient not to erase them, not to clean them, basically.
Mm-hmm. And maybe two more small basic questions. So is it also possible to image areas in the face or the forehead? And how long does it actually take to perform a measurement with the RSOM?
Mm-hmm. So motion plays a big role for RSOM quality. And so the resolution is 7 microns, so very tiny sources of motion affect the quality. And then in the head and on the face, in our experience, there is a lot of motion. It is known that the head moves in the order of microns when the heart pumps the blood basically, and then also the face. There are a lot of muscle. There are a lot of muscles that move the tongue, the mouth, and so on. So in our experience, the head is a difficult target. The acquisition time for the system I've been showing here is 1 minute for a field of view of 4 by 2 millimeters. But I think that now the system that Ithera has is faster, right? There is a fast version of the system which goes to 20 seconds, 30 seconds. I'm not sure about this. Anyway, still you can try and image the forehead and the face and so on, and see the results, and yeah, it depends also on which is your target. So if your target the larger microvessels, then you are fine. If you want to see the smallest microvessels, then you might run into trouble.
Okay, great. Okay, then thanks also to you again for your great talk and this nice presentation. And I think, I think with that we came to an end of our today's webinar, and it was a really great session. And it was a pleasure to welcome such great speakers from all around the world and to see how RSOM research evolves, and how much interesting features this really brings out for disease monitoring and therapy follow-ups. And I would obviously like to thank again our speakers, Andrea, Dinish, Amalina, and Juan, for your very great talks and for taking the time today to present your interesting results to this broad audience today. And if any of the attendees would like to have more information, please feel free to reach out either to the speakers themselves or to myself and Ithera, and we are happy to give you more information or also discuss particular projects with you if you're interested in seeing or using such a device by yourself. Thank you all again for your time today and your interest in this webinar. As I mentioned before, you will receive the YouTube link in the next days. And with that, I wish you a really nice rest of your day.